Good afternoon, good morning and good evening, everybody. And thank you very much for joining us for this final webinar of the series, COVID-19 and HIV. And today's theme is focusing on adapting community-based HIV services during a pandemic. My name is Dr. Lucy Stackpole-Moore, and I'm the Director of HIV Programs and Advocacy with the International AIDS Society. Our aim for this webinar series is to provide an opportunity for discussion on the pandemic and to have a deeper look at how it impacts on people living with HIV and other aspects of what we can learn from the HIV response and apply it to COVID and vice versa. We'd also really like to recognise and celebrate and appreciate the enormous contribution made by IAS members in every corner of the world to the local response to the pandemic, and also help connect some of the learning that is taking place in different parts of the world together to create what I'm sure is going to be another and absolutely fantastically interesting session today. Just before we start, I'd like to run through a couple of housekeeping rules. Please note that due to the high number of attendees, all participants are muted, but we do really value your questions, and please feel free to send them through in the Q&A box that you'll see down at the bottom of your screen. If you go in there, you'll notice that there's a thumbs up symbol, and you can feel free to like someone else's question or identify that as a particularly important one. That will help us prioritize that for response during the question and answer session at the end of today's webinar. We've planned for 30 minutes there after the presentations from the speakers, so please do send in questions through the Q&A box. If you have anything for a specific speaker, please do indicate that, or just a general question for the whole panel. In case you are having any connection issues with the Zoom platform today, you can find additional guidance in the chat box, or do put a comment in there and someone will be able to assist you with any IT related issues. Please kindly do remember to focus your questions on today's topic, which again is how community-based organisations have adapted their HIV services during the pandemic. There are many other questions on the portal on the IAS website, and also from the 5 previous webinars in this series, so please do refer to those as resources for your other interesting and unanswered questions from today. You can also send questions as well as suggestions that you'd like to see addressed on the portal, if it's not there already, to an email address, which is coronaquestions@iasociety.org. I believe that email address will come up in a slide in due course, and it will also be up at the end of the presentations today. The moderator for today's session is Kate Thompson with the Global Fund to Fight AIDS, Tuberculosis and Malaria. Kate is just having some challenges in joining today's webinar. So for the moment, I'm your moderator and we'll hand over to Kate in a warm welcome when she joins us as soon as possible. So without further ado, I'd really like to welcome the first speaker for today's panel, Dr. Chris Okolo, and he's an infectious disease physician and currently working with FHI 360 as a technical director for the PEPFAR USAID funded HIV prevention, care and treatment program that focuses on key populations, also known as linkages. He leads a team of technical experts that are implementing the program across Africa, Asia, Latin America and the Caribbean. And Chris has more than 26 years of clinical experience, including more than 20 years experience specifically in HIV prevention, care and treatment programs in resource limited settings, and the provision of HIV services to key populations, focusing primarily on men who have sex with men and female sex workers. So thanks so much for joining us today, Chris, and over to you. I'm really looking forward to your remarks.
Yeah, thank you very much, Lucy. Thank you for the wonderful introduction. So today I'll just be sharing with you very briefly what some of the measures that we consider very, very crucial when we're looking at adapting services for key populations, particularly at the community level. Next slide, please. So this is the outline. I'll share some experiences, some things we're seeing from the field in terms of how COVID is beginning to impact HIV programs. I'll talk about some of the mitigation measures, and then how some of our countries are adapting to COVID, and then conclusion. Next slide, please. So I'm sure most of us are aware in terms of some of the restrictions and curfews that are in place in most countries. And these curfews and restrictions are currently impacting community-based activities, particularly outreaches, including even provision of clinical services at hotspots and community-based sites, such as drop-in centers. We're also seeing disruptions to HIV testing services and difficulties with accessing ART services, particularly for individuals who are newly diagnosed, as well as those who have been on treatment, in order for them to continue to receive their treatment. But something that's very important that we're seeing across multiple programs is the anxiety among program staff, among healthcare workers, and even among the clients themselves, because everyone is scared and anxious about contracting COVID. So a lot of clients are very hesitant going to facilities or going to community-based sites to access services. And of course, as we're all aware, we're beginning to have, increase in the reported number of cases of violence. And because we know we're dealing with key populations, there are people who are stigmatized or are discriminated against, even without COVID. So with COVID again coming in, in a lot of settings, people are using this opportunity to continue to violate even the rights of key populations. Next slide, please. So within the linkages and EPIC program, we have highlighted 3 key areas where we think HIV programs, particularly those that focus on key populations, need to focus on. Number 1 is to safeguard the providers and beneficiaries. So we need to protect our providers and beneficiaries so they don't contract COVID. Number 2 is to support sustained access to HIV services. And number 3, we need to monitor and improve client outcomes even under the pandemic. And all these are aimed towards ensuring continuity of HIV treatment, testing and prevention for key populations, and PL-HIV in general. Next slide, please. So in terms of safeguarding providers and beneficiaries, which is very important, if people are not comfortable going to uptake services, then we're going to have reduction in the number of people who are coming forward. We're also going to have reduction in the number of service providers who are available. So overall, making sure that we prevent COVID infection among all beneficiaries as well as all program staff. So all the relevant PPE and washing, access to hand sanitizers, physical distancing, all these are very, very important. And we need to make sure, even at community level, that they're strictly adhered to. We also need to support COVID-19 related screening and care among beneficiaries and staff. So making sure that those that we've screened, those who have symptoms suggestive of COVID are linked to appropriate testing services, and those who test positive are linked to treatment as soon as possible. But also making sure that our community-based organizations, our CSOs, are supported and they provided guidance as to how to respond, particularly when their staff who are the frontline workers when it comes to key population programming, when they come down with COVID or any of their staff, present with symptoms suggestive of COVID. And we should also use the opportunity of COVID to help address some of the broader needs that key populations actually require or need at the community level, and also consider implementing safety holistically. So we shouldn't just focus on COVID, but we should use the opportunity that we have right now to also look at all the other things beyond COVID, beyond HIV, that are very, very important to key population members. Next slide, please. The second component is sustained HIV service connection. So from HIV testing to HIV treatment and viral suppression. So we need to make sure that we continue to deliver HIV outreach services where possible. And a lot of countries, I'm going to give some examples, are now moving from the physical space to online space, virtual spaces, over telephone, social media, just to remain connected to service beneficiaries, and also using the opportunity to leverage on HIV self-testing, particularly in settings where these commodities are currently available and they're allowed. It's actually a very, very important opportunity for us to scale up HIV self-testing services. But also making sure that all those who are reactive are linked to confirmatory testing and eventually linked to ART services. Among those who are currently on ART, so issues around ensuring multi-month dispensing of ART and relaxing some of the guidelines or some of the criteria for multi-month dispensing in a lot of countries is something we're witnessing right now. So countries are now more flexible to ensure people access multi-month dispensing of ARVs, including home delivery of ARVs, delivery of ARVs at drop-in centers, particularly for refills, community-based pickups, and even in some countries, online pharmacy. People can actually go online to request their medications and they are mailed to them. And also ensuring safety, safe and sustained adherence and retention support for all the clients. So including using SMS, telephone, social media platforms, and online reservation hub that linkages and EPIC. The 2 projects are currently trying to scale up across multiple countries, but also making sure that those who require viral testing, able to access the service, including use of dry blood spots at community level, sample collection at drop-in centers. These are all things we need to keep in mind as we continue to provide services for our key populations. Next slide, please. Here, just to emphasize that there are other services that are very important just beyond HIV treatment. So making sure that multi-month dispensing of supplies, including condoms and lubricants, people have access to SCI services. We need to prioritize access to mental and psychosocial support. It's something that's very important, and I'm sure everybody on this call understand why this is important. So, TB services, making sure that people have access to reproductive health contraceptives as needed. For PWID, people who inject drugs, making sure they have extra supplies of needles and syringes and all that. So all these wraparound services that will also help ensure that people remain safe, remain free from HIV, and those who are HIV positive continue to access all the services. Next slide, please. In terms of tracking, we also need to ensure that adequate supplies of relevant data collecting tools where they are available, we need to move to virtual or online tools where possible, and making sure that we're able to track the impact of COVID on our programs, as well as track the impact of some of the mitigation measures we have in place, how they're helping us to address some of the gaps and challenges that we're facing right now within our programs. Next slide, please. Just a few examples from our countries. So a lot of our countries now, they develop new or they are leveraging existing social media channels to maintain contact with their beneficiaries. We're using online approaches for making connections and referrals. For example, the online reservation app that Linkages is using in some of their countries. If outreaches are possible, and we know in most settings now, physical outreaches are no longer possible because they have to maintain social distancing and all that. So virtual pre-screening and making sure that all the clients that are coming to all those outreach venues are individuals who are free of COVID-19 symptoms. We need to comply with IPC measures. So holding outreach activities outside, ensure good ventilation. Our countries are ensuring that they provide water, soap, and sanitizers, and face masks, and all, making sure that all the IPC measures are adhered to as much as possible. Also making sure that we work with Ministry of Health so that activities that our peer educators and outreach workers are engaged in are understood as pro-health and not necessarily increasing the spread of COVID, because there have been reports from some of our countries that peer educators have been arrested, they've been molested at community level because people think they're just moving around spreading COVID. Next slide, please. In terms of HIV testing, I've mentioned HIV self-testing, so making sure that individuals who require assistance, that we're able to provide the assistance online using Skype, over telephone. We prioritize the use of HIV self-testing within index testing. So instead of bringing clients or bringing partners to facilities, if possible, we offer them self-testing. Consider home-based testing. So some of our countries now, instead of going for outreaches and testing at hotspots, they're now testing individuals at their homes or at places that our clients consider to be safe and secured for them. Also making sure that we're able to leverage on the power of social network testing strategies and ensuring that those we reach are able to get linked to testing services as soon as possible. Next slide, please. For clinical services, of course, we know multi-month dispensing. So 63% of the programs that we surveyed recently have moved to 3 to 5 months multi-month dispensing. A lot of them are now going online in terms of ensuring connection to their clients on treatment. They're setting up satellite sites for ARVs, and countries are moving to home delivery. We have a few countries now where ARVs are now being delivered at home, and they're making sure that with task shift and making sure that other staff, other program staff or providers within the program are also able to have, to gather some skills so that they can also step in when maybe staff becomes sick or are not available. Next slide, please. Just a few examples. This is from our Nepal program that is showing, if you look towards week 16 and week 17 in the months of April, you notice a significant improvement in terms of the proportion of clients that are now receiving their ARVs at home. And that's the one, that's the gray, the third bar. So a lot increase in number of individuals who are receiving ART at home. Next slide, please. This is from Indonesia, also showing, the proportion of people in Indonesia. They had some, a degree of shortage in ARVs, but we can now see that now they are moving more towards 2 months dispensing of ARVs, and a lot of clients are now beginning to receive ARVs at home. Next slide, please. Okay, so in conclusion, just to emphasize that key population program staff, including beneficiaries, need to be protected. So everyone is safe as much as possible. All the preventive measures, high-paced measures are in place to ensure that everyone is protected and safe from COVID. And we should make sure that programs have in place necessary measures to ensure uninterrupted access of key populations to all HIV and wraparound services. And we should think about how to track the impact of COVID on our programs and the benefit or the added value of some of the measures that we're putting in place to help mitigate the impact of COVID. And for all that I've talked about, including additional information, you can actually go to our website. That link is active. You see a lot of materials that we produced that will help individuals to further understand what are the measures that need to be in place to help ensure that COVID does not negatively impact KP programs. Next slide, please. Just to thank you very much for the opportunity, and to all our partners and to all our clients and the countries where we're implementing. And thank you to IAS for the opportunity. Thank you very much.
Great. Thank you very much, Dr. Chris Okolo, for a fascinating presentation. And I think this notion of HIV and other wraparound services is essential in these times, and will be interesting to also be able to respond to some of the questions coming up already at the end of the webinar. And thank you, Chris, also in advance for staying on the line and being available to answer questions at the end of the webinar. It is now with great pleasure that I'd like to welcome Kate Thompson, who has been able to connect now and will be moderating the rest of the panel session for today's webinar. Kate Thompson is the Head of Community Rights and Gender and Civil Society Hub at the Global Fund to Fight AIDS, Tuberculosis and Malaria. Thanks very much, Kate, for your perseverance with the technology, and handing over to you now for the moderation.
Thanks so much, Lucy, and good afternoon, good morning, good evening, everybody. Thanks for joining us around the world, and sincere apologies for joining you late. As they say in the UK, better late than never. So thanks, Chris. I caught most of that presentation. It was fantastic. And moving on now to the next presentation, I'd like to introduce Shurang Jayam, who will present on adapting sex worker services during the COVID-19 pandemic. Shurang is the founder and director of Service Workers in Group Foundation, otherwise known as SWING, which is registered as a non-governmental organization established in 2004. SWING's aim has been for protecting the rights of sex workers in Thailand. She's also a member of the Men Who Have Sex with Men Community Advisory Board in Bangkok, and of the Community Advisory Board of the Project for Development of HIV Vaccines, Medicines and Related Products of the Thai Red Cross and AIDS Research Centre. So with that introduction, I'd like to hand over to Shurang. Over to you now. Looking forward to hearing what you have to say to us today.
Hello, thank you very much. Okay, good evening. Okay, for today, I would like to share with you what we have to do to support the sex worker during the COVID-19 situation in Thailand. Next, please. In March of 17, that is when the Thai government they are locked down the entertainment business. We found that it's more than 100,000 of the sex workers they lose a job, they lose income. A few days after the government they locked down the business, that's okay. So when we get the phone call from the sex worker, they call us and they need some help because they say it's okay. They are really hungry because they don't have enough money to buy food. And then after that, okay, next please. After that, next please. After that, okay, in that day, swing staff have to go to the community and then to try to find how many sex workers they need a support, they need a help. And then we found that it's a loss of the sex worker. They still have in the bar, and then they don't have enough money, or some of them they cannot return home. And then we start to provide food for them. Every Monday, Wednesday, and Friday, staff, they have to turn themselves from the outreach worker, they turn themselves from the counselor to be a cooker. They had to prepare around 300 food pack in each area, and then distribute to the sex worker in Bangkok and Pattaya. Next, please. Next, please. Another problem that's coming that we face when we distribute the food that we found is a loss of the sex worker. They become a homeless sex worker. That's because they don't have enough money to pay for rent. And some of them, they are the homeless sex worker. They are ARV stock out. That we have to helping them to link them to get the ART for make sure that they be safe from HIV. And also in another part, when we found that okay, some of the sex workers who really want to go back to the hometown, but they cannot because they don't have enough money to pay back to the hometown. We helping them to for the transport, and also we give them some of the pocket money for make sure they can return home safely, and then they can stay with the family. We are so lucky that because we got a lot of the support from the people who have a very good heart. Some of them, they donate the money. Some of them, they are donate food and the item for sex worker. Every day we have a lot of the donation is coming to our project, and then we can help more sex workers who need our support. Next, please. The donation is still increased, but what we have to do, do that is for transparency management. Every Saturday that we have to post in the social media to show that how much money that we get from the donate, and also how much that we have spent for report to all of the people who are the support us during this time. We found that in 1 month that we get almost 2 million Thai baht from the donation from the individual person and also from the business sector. That is very support of the sex worker. Next. During that time, okay, in one hand, we have to helping us to solve the problem for the COVID among sex workers. But in another hand, we have to continue the HIV service. When the government, they say that they let everyone stay at home, but for us, we cannot stay at home because our brother and sister, they are still hungry, and then we have to come to our clinic, we have to come to our office. That's okay. Our clinic have to open every day to provide the HIV testing and also provide PrEP. And also we do the mobile HIV testing and also the mobile of the COVID screening for the sex worker, also for make sure everyone will be safe from HIV and everyone will be safe from the COVID. In another side, that's okay. We found that is for the sex worker who are HIV positive. That's okay. Our care and support team, they work very hard for make sure everyone, like 800 of the sex workers who are live in Bangkok, for make sure that they have enough ART, and also for 700 of the sex workers in Pattaya, they have enough of the ART. For some of them, they cannot traveling to get ART in the hospital. Our case manager will send them ART at home by post. Next. Next, please. Okay, that's okay. We are not only to do a HIV testing. In another role of us, that in April, we have the collaboration with the government in the province, and we can help more than 500 sex workers to receive the COVID screening. We turn our skill from KPLHS that we can provide the HIV testing by ourselves. We be at the same team with the government and then to do the COVID screening with for sex worker. During that time, that we think that is the information is very important. We need the information to report to the government. What we do the committee-led rapid assessment COVID impact of sex worker. We have collect data from the 234 sex worker. That's okay. In that time, that is wonderful. We get a lot of the interesting message, interesting information, and then we use that information to plan what we have to helping them in the future. And then also we use that information to advocate the government that they have to do something to support the sex worker during this time. Next. What we learned, we found that if we find that is our target group, they face a problem. We cannot sitting and waiting for someone to helping us, but we need to be quick to helping them. Anyway, the problem could turn to be the opportunity. Like for the COVID situation in this time, we can see that the change in the society attitude among sex workers. We have met a lot of the people who come to help the sex worker. They say that why they come to help sex worker, because they said it's even they are sex worker, they are human being. They need a support. If they are hungry, they need food, they need a support as another people in the society. That is make we have more energy to helping more sex worker. For next, for our plan in the next step, we believe that sex worker we continue to face a lot of the problem for a long time than another people. The fundraising activity have to continue. That's okay. What we do right now is we selling the t-shirt to making fun, and that money we can use to support the sex worker. And also we collaborate, work with the business sector. They do the fundraising for us. And also in another part, that for plan B, that we found that is many of the sex workers, they decide maybe they will not continue to be a sex worker anymore, because they know it's not easy and also very difficult life of them to find the customer, and very difficult life for them to make them to be safe all the time. We already have discussed with the business sector that they try to employ the sex worker who want to leave a job to get a new job. That is very lucky. For next month, we will have 5 of the sex workers. They will be staff of one of the company that they will get a very good salary from that company. That this is from the collaboration with the swing and also the business sector. Next. This just some of the message, the thank you message that we got from the sex worker when we distribute the food and also many things to support them. And then many of them they say thank you, and then some of them they just cry, because since they face the problem from the economic problem, they did not get the support even from the government, even from the people, but just only our organization to go to visit them and helping them in every day. I would like to say thank you very much for not leaving sex worker behind. Next. This is you can follow us from our Facebook, and also you can see it's a lot of activity. That is sewing staff. They spend a lot of energy to do the good work to support our sister and brother, for make sure that is our sister and brother sex worker will not be alone. Thank you very much.
Thank you, Sarang, for a really inspiring presentation. I think you've really given an incredible example of how communities, marginalized communities, sex workers in particular, in the face of great adversity and challenges, are really being proactive and creative and taking charge of the response themselves. But also, I love that message that you gave around how you were using this situation as an opportunity, and an opportunity to really push for a reset in how sex workers are regarded by the rest of the community. So thank you for that, and I know that you'll be staying on for the question and answer session. What I'd like to do now is to introduce my old friend and colleague Anton Basenko, who will present on maintaining harm reduction services during the COVID-19 pandemic. Anton is the country focal point of the PITCH program at the Alliance for Public Health in Ukraine since 2017. He holds a master's degree in international economy and is a globally known activist of the community of people who use drugs and OST patients. He's openly living with HIV. In 2010, he started his work in the HIV and TB services, harm reduction and advocacy fields in local and national NGOs in Ukraine. Since 2013, he's been working for the International Alliance for Public Health, coordinating international and national projects of HIV, TB, viral hepatitis prevention and treatment amongst people who use drugs. He's the author of a number of different articles, guidelines and publications for communities and professionals. And he's also a board member of INPUD and ECIN. He's a member of the communities delegation to the board of the Global Fund and represents people who use drugs in the CCM of Ukraine. So over to you, Anton.
Thank you, Kate, for such a good presentation of myself. Yeah, first of all, everything I'm going to speak about in my presentation is, of course, a part of my personal and professional experience, different challenges and successes. Next slide, please. So you will see the list of services which were introduced or catalyzed or were simplified, what makes them really accessible and sustainable for further implementation. So let's start from basics. We all know that the main component of harm reduction is needle and syringe programs and distribution of different supplies, usually provided through traditional outreach work. We also know that this is excellent entering point to the cascade for people, HIV cascade for people who inject drugs or for people who use drugs. But also, as we now know from the Lancet publication, the people who use drugs as such are key population regarding COVID infection. So why it is called harm reduction to zero? Because COVID reality made us to reconsider the traditional approaches, not only how we distribute, but what and how much. In majority of Eastern European and Central Asia countries, and I will concentrate not only on Ukrainian examples, but speaking also from the regional perspective, because there are quite good joint examples. So in majority of Eastern Europe, Central Asia countries, the volume of harm reduction supplies, disinfectants, condoms, lubricants, syringes, alcohol wipes for clients increased for the period of 1 week to 1 month. It's not only the number of supplies, it's also the other ways of distribution, like kits, safe boxes, sent by mail, couriers, or left in special stash points. Regarding number of syringes, actually, I really like this increase, because I was always concerned about WHO recommendation about 200 syringes per year. Why it's not 365 syringes, I've never understood. But yeah, so now I think it's really enough for clients who requested. Next slide, please. Syringe dispensing machines, which is quite new for our region, but some countries like Georgia already started to pilot. Some countries like Ukraine just submitting this within the new Global Fund proposal. But this is absolutely good response in implementation of harm reduction programs in terms of COVID, because It's discrete electronic machines which provide stereo injecting as well as other non-injecting equipment. These products provided for free or at low cost. These increase access and reach, including the geographical reach, 24-hour accessibility, may attract people who inject drugs, and not only reduced overhead costs, and of course client anonymity. Next slide, please. Online consultation and generally distant consultations like telephone, social networks, email, etc., became the major method of work with the beneficiaries. For example, in North Macedonia, the need in online counseling increased by 70%. Georgia, more than 700 consultations are provided online. Good example from Ukraine, where the national hotline on substitution therapy and drug use, only during the first 2 weeks of COVID lockdown, 50% increase of the number of calls. Distant counseling significantly increased also with a view to limitation of transportation. So readdressing in connection with psychologists and psychiatrists is also ensured, for example, in Romania and not only. Next slide. HIV self-testing is also a brilliant example of how services can be improved because of COVID. It's fully functional in Kazakhstan and Georgia. Minimum 150 clients in each of the countries received saliva self-tests ordered by them. In Ukraine, we also use test dispensing machines and the high number of self-tests distributing through these points. So wide-scale introduction of test dispensing machine can contribute to increase of number of HIV self-tests. Next, please. Of course, talking about harm reduction programs, we are not talking only about needle and syringe programs. We are talking about really integrated programs where people who use drugs completely referred to the HIV treatment if they are positive. And it was already mentioned in the first presentation, of course, the alternative options of distribution of ARV taking place now in terms of COVID. So ARV by mail is really new for Ukraine as well as for the region. There was also another slide about the ARV with the courier or using mobile clinics, bringing the treatment to the home. But I guess the other presentation will more concentrate on this. So I would rather concentrate on ARV by mail, but also it's cost-effective service, and actually ARV delivery to home by courier service or by mail is a practice used by majority of countries for quite a time. However, it became very important under the conditions stipulated by the COVID-19. So we are talking not only about the way of distribution, but also the term of distribution, because the drugs were given maximum for 1 month in some countries before, but no, in Ukraine up to 3 months, but now this period is extended in some countries for 3 months, like Kyrgyzstan, in Ukraine till 4 months or up to 6 months. So people should be ensured that they have enough storage of ARV at home. We are not talking exclusively about antiretroviral therapy. Of course, TB drugs now also distributed for the period at least 2 weeks, like in Kyrgyzstan, Ukraine, and Georgia, and the Hep C treatment, the same approach as well. The need in ART delivery to home increased by 70% in Georgia and by 50% in North Macedonia. In Kazakhstan, in all the regions, ART delivery to home is ensured for those who need it. As regards to the patient who faced lack of drugs and are not at home, but in other city or region, the online service of temporary registration in the current place of residence is also available. Next slide, please. The other key component of harm reduction, opioid substitution therapy, we know that for the stabilizing or for the induction phase, or there is used the daily approach of distribution of drugs, and some countries, unfortunately, they are not using take-home dosages, but COVID-19 situation really gave the huge push, because after the COVID-19 pandemic and quarantine, OST substitution therapy became available for taking home for the period of 5 to 14 days in some Eastern Europe, Central Asia countries, in particular Moldova, Estonia for 2 to 4 days, Kyrgyzstan up to 5 days, Poland and Romania up to 14 days, Georgia, Lithuania 5 to 7 days. So in Moldova and Ukraine, the opportunity of taking opioid substitution therapy home existed before COVID-19, but the number of patients moved to take home dosages was fantastically increased, and the number of days was also increased. So let's take Ukraine as example. As of April 1st, 2020, there were 13,000 of substitution therapy patients in Ukraine. It's the biggest OST program in the region. Before COVID-19, about 50% of them were allowed OST take-home doses for the period of up to 10 days. By the end of April, with the lockdown, 90% and now I have a figure, even 95% of the patients received the OST for the period from 10 to 15 days in one city, even up to 30 days for take home. So all these patients are provided with the distant counseling services, of course, because psychosocial support of substitution therapy is a quite key element. It's not only the distribution of drugs, and also the substitution therapy sites working hours was optimized as a consequence of the quarantine. Transportation limitations issue. The hotline, National OST hotline, helped to patients to issue travel tickets or special badges for the patients which have to visit OST, whether it's daily or one time in 10 days. And next slide, please. So we're coming to the conclusions and recommendations for changing services after COVID-19. What really works. So take home OST drugs for a period of at least 14 days, as I mentioned, distribution of harm reduction supplies, and not only, because talking about the COVID specificity, all harm reduction patients in Ukraine and substitution therapy patients were provided with the COVID prevention things like masks, gloves, disinfectants. So I think some of these supplies should stay the part of the kits, and these supplies should be available up to 1 month. Delivery of supplies to clients of harm reduction programs through the mail or courier services or stash points. Introduction to the practice and popularization of tests or syringe or condom dispensing machines. Increase of online consulting services, whether it's telephone or social networks, different messengers or hotlines. Expansion of self-testing, we definitely need. Delivery of antiretroviral therapy drugs up to 3 months and more. Delivery by mail, especially if it is possible for the patient, if it's impossible for the patient to come and receive drugs in a medical facility. And of course, the possibility of temporary registration, if it's actual for particular countries where it's a legal condition to receive ARV at the place of residence. Next, please. So looking forward to your questions, and hope that we all will keep and develop these successes, because the COVID-19 lessons gives us the real window of opportunities for non-governmental organization, as well as for key affected communities like people who use drugs. Let me remind you that now the process of country preparation of proposal to Global Fund taking place, and this is also good window of opportunities to include some best examples, best activities, and to the new proposals. And thanks to IAS for invitation. Thanks, Kate, for facilitation. Thank you for your attention.
Thank you so much, Anton. And it's great to hear about some of the adaptations into service delivery that we're beginning to see. And I would agree with you. Let's hope that post COVID-19 that some of these remain in place and continue to evolve to better meet the needs of people who use drugs, but other key populations as well. And so now moving on, it's my great pleasure to introduce Professor Mede Kakuri, who will present on ensuring access to HIV treatment in lockdown. Professor Kakuri is a professor of medicine and the president of ANCS, the Association de lutte contre le sida, which is a community-based organization established in Morocco way back in 1988. The professor has been particularly involved in HIV testing and counseling activities, research and training, and he's the resource person for anti-stigma and discrimination policy. He's also been involved in the MENA region, having undertaken missions in several countries of the region and acted as a consultant for various international organizations such as WHO and UNICEF and the European Commission. Today, he's also bringing us the voice of the work done by the organizations that are part of Coalition Plus, for which he is a board member. So over to you, Professor Kakuri. Professor Kakuri, you on mute? Professor Kakuri, are you there? And if you are, we can't hear you.
And now, can you hear me?
Yes, perfect. Can hear you now. Over to you.
Sorry about that. Thank you for the introduction. And I just wanted to say that I am here today more as my capacity of an activist and president of a community-based organization than a professor of medicine. So thank you for the introduction. And the next slide, please. So today I will talk how we ensured access to HIV treatment during the lockdown. I will speak, of course, about ILCS, my organization that I know most, but I will also talk about the situation, which is pretty the same in all the organizations that are member of Coalition Plus. So this COVID crisis raised almost overnight some challenges that we, community-based organization, found ourselves facing. So we had a series of questions that we had to find the answer to: how to ensure continuity of our services, how to adapt our field work to comply with the distancing and the new social norms. Most of our work involves field action and close contacts with clients, yet the virus thrives on close contact. How to pass on prevention messages and how to continue to meet the needs of people living with HIV during this, this period. Next slide, please. So we started by an advocacy because we had to talk to almost everyone and every institution to get everyone on board. We had to talk with the government and the health authorities regarding how we are going to organize the continuity of care and prevention. We had to talk to the police and the security forces regarding the need to relax some of the travel restrictions for patients, clients, and also for providers. We had also to talk to donors regarding the necessity to reallocate funds in order to address new needs of the community, such to make available all these protective personal protective equipment, for example, and also to address, and we've seen that in the previous presentation, the huge socioeconomic vulnerability that is now stemming from the lockdown and movement restrictions. And of course, we had also to talk within our communities to make sure no one is left behind. Next, please. So first we went to gather all the scientific information available on how this virus is transmitted, what are the preventive measures to put in place, the protective equipment, the new environmental and engineering controls, and also we sent all our non-field staff to work from home whenever this was feasible. Next, please. So concretely, we went to see the national aid program and discuss our options. We told them, you don't want your infectious diseases departments to be overflowed by people living with HIV showing up just to get their monthly or whatever period supply of ARVs, and that's right. Infectious diseases departments are at the very forefront of this COVID response. And also, on the other hand, we need to have people living with HIV avoid unnecessary exposure to coronavirus just by visiting hospitals, if we can avoid that. So we were very proactive at doing that. We had discussion with the AIDS programs. And we asked to be part of the discussion, to be part of the governance, and that we were represented in each step of the process. So we worked all together on a plan to dispense the supply of at least 3 months of ARVs through a variety of methods. Next, please. Community agents would reach out to those who did not already collect their treatment and ensure timely distribution, either by organizing home deliveries, like we can see in the photo on the right, or sending it by courier or by mail. And moreover, the community agents would make themselves available for ongoing support for adherence through phone, WhatsApp, and social media. And this is quite new for us. And of course, we extended the services to the tourists living with HIV that are stuck away from home and running out of treatment. Next, please. We also wanted that all essential HIV prevention services were made still available. And I think that this was addressed in previous talks. Of course, providing some adaptation and respect of the new social norms and the physical distancing, like we can see here, using protective equipment. Also, we had to continue to run our harm reduction programs, like we can see on the photograph on the left. Next, please. We also felt that it was crucial for us to get still involved in our role of watchdog, to report and work on to avoid disruptions in the supply chain of ARVs and protective equipment and stockouts, by monitoring their use and their distribution. And also we had to share between us mutual experiences on how one can rationally use personal protective equipment, and also some tips on how to overcome shortages. Of course, during the period of the lockdown, because of the stress and all the anxiety that is generated by all the virus and the lockdown, we know that we had an augmentation in intimate partners violence. So we made sure to address that by support, by education, and also by legal aid, and also by continuing our work against stigma and discrimination. Next slide, please. So in conclusion, I can draw on some of the key lessons that we learned during this pandemic. Involvement of communities has always proven to be the key to the success of any initiative. Communities were somehow involved in the whole process of reshaping the HIV services, even if not everywhere, even if not always at the same level, but we were glad that we were in. Our capacity of adaptation is phenomenal. Community-based organizations active in the HIV field have always been very flexible and very keen to adapt to a very changing environment, and this crisis is no exception. We also go for our rights, and we don't hesitate to move forward this is very important. For example, I can give the example of Morocco. We know the Ministry of Health and the medical community was classically very reluctant to implement the community dispensation of ARVs because doctors felt that we were taking from them some of their power. But the COVID crisis, I can say it like saved us months, if not years of lobbying, as we successfully showed that we can implement that. And we, of course, plan to continue to do that after the relax of the lockdown. So in fine, we see this pandemic, we see this unprecedented crisis, health crisis, economical crisis, societal crisis, more as an accelerator and more as an opportunity to move forward. Thank you very much.
Thank you so much for a great presentation, Professor Mehdi. And I think that you raised so many issues there, including the need for multi-pronged, multi-focused advocacy, the essential requirement of community engagement across all different elements of responses. We've seen how that's happened within the context of HIV and how HIV communities are adapting in very creative ways to COVID. And I think that we're seeing those kinds of approaches now taking root amongst other communities for COVID as well. It's something that I've been spending quite a lot of time working on recently, and then also the importance of community-led monitoring to monitor what's going on the ground, whether it's stockouts or human rights and other elements. So thank you so much, and I'm now going to turn over to Matha Mawadezeki from Africade Spindari in Zimbabwe. And Matha is an HIV specialist who's currently working as the head of programs at Spindari, where she spent 13 years working together with the government of Zimbabwe to improve the quality of life for children, adolescents, and young people living with HIV through differentiated service delivery. She's the holder of a Master of Science in Development Studies and has experience in managing regional and international donor grants and contracts. Matha's true passion, however, lies in the development of innovative, effective community interventions which complement facility-based care in promoting both health and psychosocial well-being of children, adolescents, and young people with HIV. And she's now going to present on taking HIV and related services virtual for youth. So over to you, Matha.
Thank you for that introduction. Yes, can you hear me?
Yes.
Thank you for the introduction. May you move to the next slide? So with the pandemic of COVID-19, which presented in our country, and I'm sure in other countries as well, it really posed as a threat to reverse the gains which were made in HIV testing, treatment and care and support for children, adolescents and young people living with HIV. And because of this, we had to come up with a response of how to address such a situation so that we protect the gains that were made in terms of our HIV testing, treatment, and care. And so by so doing, we had to adapt our intervention, which is the community adolescent treatment supporters, whom are normally called kids. These are young people who were mentored to be peer counselors. So in the unusual setup from those pictures, which you can see, they would conduct home visits, joint home visits, clinic-based support groups, health for their peers. But because of COVID-19, we had to adapt our intervention to ensure that we do virtual case management so that we reduce our client contact beneficiaries. We also do virtual case management, and to ensure that we keep our clients connected, we also had to run to e-support groups, which encompasses the clients and also the caregivers. And Health, since this is something which we had already started as an organization, this is still continuing to be going on in response to COVID-19. Next slide. So we have got 5 pillars that we look at in terms of how can we support young people living with HIV. So the first pillar that I'm going to talk about is on information sharing, where we are aiming to ensure that children, adolescents, and young people have got access to peer-led, evidence-based, appropriate information, which will always support them to make informed decisions about their health and well-being, and also to support positive mental health well-being. As you know, in such a crisis, there is a lot of anxiety and depression. So our information sharing is really aimed at trying to give appropriate information. And some of you would have seen the popular Fatima video, where Fatima is talking about coronavirus. The main aim is to disseminate age-appropriate information so that young people also get to understand that they are not spared with COVID-19, and also that how is it the relationship between COVID-19 and HIV. So to be sure we disseminate this information, we've developed a variety of formats in different languages. This include films, comic strips, fact sheets, and all these materials are also disability sensitive to ensure that we do not leave anyone behind. So these messages are disseminated through WhatsApp, SMS, radio, and also on the national television, where everyone has got access to. So these are some of the materials that we have developed to ensure that we push out accurate information in such a time as this. Next slide. So in terms of virtual case management, and the goal is to continue to be engaged so that young people living with HIV, including children, continue to be engaged, monitored, and supported with adherence, retention, and positive mental health. And also that red flags are identified early and managed appropriately so as to protect the gains that were made in the response to HIV. So the kids are usually assisted by the Zandiri mentors. These Zandiri mentors are professionals who work with the kids to support them to manage their caseloads through WhatsApps or SMSs. The management of these caseloads is to ensure that all children who are on the program receive the necessary support that they require, and also that we are able to pick up on the red flags as these are identified early. So the SMS usually will be through how updating on when and how to collect ART from the clinics. As you know that in such a pandemic, there are a lot of information moving around where some will not be so sure if they are able to go to the clinic. ART and adherence monitoring and support, which also include enhanced adherence counseling for those individuals who have got a high viral load, is also being offered virtually. And active screening for signs and symptoms of possible COVID-19 amongst the cohort that we are supporting. Psychosocial support and mental health check-ins for the cohort that we are supporting to find out how they are coping in such a crisis, how they are coping in this normal way of living where they are locked down in their houses, and also screening and the identification of red flags, like I mentioned earlier, to ensure that anyone who is lacking their ART or anyone who is sick, anyone who has got psychological distress are immediately referred to health facilities or to the appropriate services which they may require. Next slide. Then on community outreach, as a program, we used to do community outreaches where we would go out into the community to ensure that we keep engaged with the clients that we support. So what has changed and what we've adapted in terms of this pillar is we've stopped community home visits, which are normally done by the kids, the community adolescent treatment supporters. So because of this pandemic, we're now doing remote joint planning and response with the health facility and other community cadres to ensure that we track and trace all children, adolescents, and young people who are not attending art review clubs. So because of this joint planning, we would know and we'll be able to pick individuals who would have failed to pick up their ART at their prescribed days, so that we do community follow-ups or we follow them up to ensure that they pick up their medicines. And even the provision of enhanced adherence counseling for children, adolescents, and young people with a high viral load is also being offered. And community art delivery for those unable to access clinic. There are some instances where individuals will fail to go to the clinics due to a number of reasons, maybe such as transport challenges, and we ensure that these are all profiled and the ART medicines are taken to the community for them in conjunction with our Ministry of Health. And we are also doing targeted community HIV self-test kit distribution, where we are saying we are trying to minimize contact with the health facility, but still people will require to know their HIV status. So through telephonic interventions, we identify those who require HIV testing kits, and this will be delivered to them. And we also, in the process, support the caregivers who are supporting these children and adolescents living with HIV. As you will know that a well-supported caregiver will also in turn support the children that they are living with. And all this is being led by the Zantiri mentors who are at district office with the remote support from the kids who are working strictly from their homes. Next slide. Then on virtual case management, where our goal is to ensure continued opportunities for children, adolescents, and young people to engage with their peers so that they continue learning, sharing, and supporting each other. Because this is one key area where young people always love to be continued in terms of engagement with their peers, and also to reduce social isolation, which has been forced by the lockdown, and promote positive mental health. So the physical support groups, which would normally happen in a normal situation, have been adapted to run as virtual support groups. And we've really received overwhelming response from the beneficiaries that we are supporting, as they are eager to participate and to remain engaged in care through these platforms. And topics so far which have been discussed to date through these e-platforms include COVID-19, HIV, ARVs, and adherence, mental health. And we are still coming up with more sessions which are going to be delivered through this platform of e-support groups. And these support groups are held twice a month, and they are also now being adapted for the caregivers to ensure that we keep them engaged and to ensure that we also address some of the fears that they could be having. Next slide. Then what are the key lessons that we have learned as we have adapted the model to be responsive to COVID-19? Zantiri is a multi-component differentiated service delivery model. It is adaptable and relevant during an emergency. Because what we've been doing before an emergency, we've managed to actually do it now in an emergency crisis through the telephonic interventions that I've been talking about. And also not to forget the flexibility of the donors for the realignment of funds. As you know that this pandemic came in while most of the funding has already been approved. So it required a lot of reprogramming and communication with our funding partners to ensure that we respond to the crisis. And they were quite flexible for us to realign the available funding. And also the continued engagement with Ministry of Health and Child Care for leadership and coordination is very critical. You see, as I had mentioned earlier, that we do community ART distribution. If it was not for the support of Ministry of Health and Child Care, we would not have been able to reach out to these individuals who may have missed their clinic appointments due to a number of reasons. And also collaboration with health facilities and other partners is essential for the coordinated response. So you see that for Africa to be well aware that so and so did not pick their medicines, it is because of this connection with the health facility and also with the other players in terms of HIV response that you then coordinate your efforts, and also the involvement or engagement of different community cadres. You'll find that at community level, we've got different community cadres who are working to provide different services. But if they're well coordinated, it is critical to reaching out to all the children, adolescents, and young people living with HIV. And virtual services also, they cannot reach to all children, adolescents, and young people living with HIV. And some of them do not have phones, and also the issue of power and connectivity in some areas. And these are the individuals that will then target with isolated home visits, and of course maintaining the regulations which surrounds COVID-19 prevention, so that we don't pose a risk to the clients and also even to the program employees. And an electronic case management tool will enable virtual case management, tracking, monitoring, and evaluation, as we are able to track who is getting what, who needs what at any given time. And with this pandemic, we will continue to learn and adapt the intervention of Zandiri. Next slide. Thank you so much to our funding partners and also to IAS for giving us this wonderful opportunity to be on this panel. Thank you.
Thank you, Mata. And again, another great presentation that really highlights the adaptation and creativity that diverse communities are really applying to the COVID response. Particularly, from your perspective, looking at what the needs of youth for information and services. I like their big focus on mental health. I think it's something that is probably not talked about enough within the context of what's going on right now. And also the point you made about the limitations of, even while the virtual solutions and platforms are great, there are limitations. There are a lot of people actually who don't have that access. So just before we go on to our last speaker, I just wanted to flag that we are a bit over time. So the IAS have very kindly suggested that we can all stay on for an extra 15 minutes, those of you who can, including speakers, so we can extend for 15 minutes and have more time for Q&A. I will now move on to our last speaker, Nisha Jagdish, who's going to present on the integrated sexual and reproductive health and rights services during COVID-19 pandemic. And she's currently working as Director of Gender and Rights Program with the Family Planning Association of India, which is a member association of IPPF Federation. She has a master's degree in medical and psychiatric social work and has 3 decades of experience in public health, particularly planning and managing programs related to sexual and reproductive health and rights and integrated sexual reproductive health and HIV, as well as women's empowerment and gender-based violence. So Nisha, over to you.
Yeah. Thank you, Kate, for the introduction. First of all, I would like to thank IAS for giving us this opportunity to share our experience. FPA India is a voluntary organization having 45 branches and projects across 16 states and 2 union territories in India. And it's one of the SRH organization providing wide range of SRH services. So in my presentation, I'm going to briefly give introduction about the COVID situation in India, how FPA has prepared itself to provide SRH services during this pandemic, the challenges we faced, and the key messages. Next slide, please. The first COVID case was detected in India in the month of January. Although there were no cases detected in February, the cases started detecting in the month of March, and the first death related to COVID was reported. On March 11th, Government of India evoked Epidemic Disease Act 1897 and announced a nationwide lockdown on March 25th to as a prevention measure against COVID-19 pandemic in India. As the cases increased, the lockdown extended. Currently, we are on the 4th lockdown phase, which is up to 31st May. So the COVID situation as on May 26th, we have 80,722 active cases, 60,490 cured or discharged, and 4,167 deaths, and 1 migrated. Next slide, please. So how did FPI adapted itself to provide SRH services during this pandemic? First of all, we partnered with the Pest Control of India for disinfecting our clinics and mobile vans. We sent technical and operational guidelines to all our branches how to provide SRH services during this pandemic. Screening tools for COVID-19 and GBV were developed, and we procured protective gears for our staff. We started with telemedicine and created a number of resources in different languages to use it in the outreach. We also approached the authorities with essential service guidance received by the Ministry of Health and Family Welfare to ease our travel restriction, because due to this lockdown, we were not able to open up our clinics and provide the services. Since the clients were not aware of the clinics open and the services available, we popularized our service providers numbers in the community, and our youth was engaged largely in popularizing about our clinic services and the clinics open. Virtual trainings and meetings were also conducted for our service providers to provide the services. We also started a mobile app to screen the suspect COVID among the clients who visit our clinics and to provide effective referral. Also, the staff engage with the local authorities to conduct the COVID survey, to screen the persons for suspected COVID and to provide referrals. We also provided face mask, food for the standard migrants and slums that were, travel restrictions and other restrictions were during this lockdown. Due to this travel restriction, most of our clients were not able to access the SRH commodities and ART drugs. So we distributed these commodities through our community-based depot holders and link workers to their doorstep. And at the same time, we strengthened the community, how to maintain social distance, how to take care of themselves, how to prevent the virus. And as you know, during this lockdown, a number of GBV related cases increased. We started providing on first line support and appropriate referrals to these clients. Next slide, please. So during the lockdown period from 23rd March to 17th May, we have provided around 241,000 SRH services to 79,510 clients. These services include contraceptives, including female and male sterilization, safe abortion services, HIV, STA, RTI, gynecological problems, mother and child care, and other SRH problems. And through the telemedicine, teleconsultation, we provided services to around 7,179 clients. Next slide, please. So while providing these services, we have encountered a lot of problems. Initially, the SRH service was not considered as an essential service. So there were travel restrictions. We were not allowed to open our clinics, and most of our branches fall in red zone areas. So travel restrictions were there. So we were not able to open up most of our clinics, and the clinics functioned with the limited staff. Due to these travel restrictions, last mile distribution of commodities, we faced challenge. And also we were uncertain about receiving the stock from the government. Next slide, please. So the key message is that family planning and safe abortion services are essential services that should be provided during any crisis. We need to ensure that sexual reproductive health and rights are not compromised, and the key population, women and girls, adolescents, youth, should have access to these life-saving SRH services. We need to educate the community with clear message on the risk of infection, because COVID is going to be there for some time. So they need to know how they should protect themselves, how to take care of themselves, and how to ensure that this virus is not spread in the community. We need to involve community volunteers to ensure the SRH communities reach our clients regularly, so that there is no stock out. We need to ensure the safety of our staff as well as our clients, so that they can receive services uninterrupted. And during this pandemic, the use of digital media is very important. Now, most of them have mobile phones, so they should access the service and information using their mobile technology. And also, lastly, we need to strengthen our partnerships so that the clients receive holistic support. Next slide, please. So I would like to thank all the service providers who are providing the life-saving services during this pandemic. And ensuring that the clients are not affected with these services. And I'd like to thank you for the opportunity, and thank you for the patience. Thank you.
Thank you so much, Nisha. And again, a very compelling call and reminder of the need to not compromise on existing services that are essential for the key populations within the context of HIV, while we're all having to adapt to the to these challenging COVID-related times that we're all now in. I think you very clearly articulated the need for to ensure the safety and security of staff. You again, as others talked about, the use of virtual technology and ensuring community literacy around COVID as well. So I would like to really thank all of the panelists here. I think it's clear that there is so much expertise and knowledge and passion and creativity amongst all of the people who've been speaking in their communities, and we need to continue to support community-based and community-led responses, despite the challenges that we're facing with COVID. These are critical, and we all have to, whether it's people like me who are working donors, or we all have to be supporting these services to go on. So I am going to actually have to leave very shortly. So I'm going to be handing over to Lucy from IAS to moderate the Q&A session. And while the Q&A session is being prepared for, I think there will be on your screens a note that hopefully you can take a few seconds to respond to, a quick poll. But with that, I will thank everybody. It's been a real pleasure to be on this call today, and to hear so many great examples of what's happening. So with that, I'll thank you all and hand over to Lucy.
Brilliant. Thank you so much, Kate. Terrific moderation, and thank you also to all of the panelists. What a great lineup, and we're so lucky to have been able to hear some of the details from your experiences. Thanks very much for your time, and also for staying on for an extra 10-15 minutes just to respond to some of the questions coming in. If I could ask, actually linking Nisha, the last presentation, with the first one from Chris. A question has come in terms of PPE and how that's provided to the community cadre of the health workforce, and who provides it, and how they're able to deliver their service in the safest way possible to protect themselves and their beneficiaries. If you have some more that you could say about how that's available in terms of community-based outreach to protect their healthcare workers, that would be terrific. Maybe first, Nisha, since you just spoke, and then over to you, Chris, after that.
Yes, what actually we have done is we have decentralized the procurement of protective gears to the branches, so that they could receive these protective gears locally and use it. This is basically for the service providers in the clinic and those who are going in the outreach.
Great, thanks, Nisha. And could you say a little bit more about what, or can you generalize about what equipment is available for the outreach? Is it as comprehensive as in clinics, or is there a modification or something like that?
It's mostly for the clinic staff, and for the outreach, it is mask, sanitizers. Mm-hmm. These are the protective gears we have, and for the clinic, they have this protective gear, complete protective gear, masks, and other while providing the surgical services.
Great, thank you. And Chris, from Linkages, your experience?
Yeah, thank you very much for that question. So within our program, because we are PEPFAR funded at the moment, generally we're not allowed to use PEPFAR funding to procure some PPE. I think when we're talking about PPE, we need to be very clear that different people will require different things depending on the work they do and depending on how much interface they do have with clients at the community level. So what we've done within our programs in a lot of our countries is making sure that the basic needs or the basic supplies, particularly soap, hand sanitizers, are things that generally we're allowed to procure. So a lot of our programs have these available. And right now that people are beginning to make masks at community level, people are also supported to have, to access some of those services. But when it comes to the actual, things like surgical masks, respirators, the gears, and all those things generally are not required at community level, except for individuals who have direct contact with COVID, patients. So we're still waiting for PEPFAR to provide additional guidance. And a lot of the, some of the organizations we're supporting are also able to source some of these items on their own without necessarily using our funds. But the general recommendation guidance we received from PEPFAR is that we're not allowed to procure a lot of those items that people will require. But the good thing is that not all the community-based workers will require all this high-level kind of PPE. So we generally use PPE as a general term, but people need to understand that there are different aspects of PPE, different components, and depending on where you are along the entire cascade of service provision, that is what is going to determine what you're going to require. But we know right now we're also unable to procure things, as simple as hand gloves, and that's a challenge for a lot of our programs, but we're still trying to figure this out and see what we can do. But generally, the simple things like, making sure people have access to water, making sure people have access to soap, as well as hand sanitizers are things that we're allowed to do generally.
Fantastic. Thanks very much, Chris. And I think useful to clarify the different types of PPE or protective equipment that can and is appropriate at different levels as well. Thanks to you both for that. A question for all the panelists, but perhaps starting with the Zvandiri example and from Mata. The questions come in, several people raise it in different ways around technology and how useful it's been during this period in terms of online consultations and booking, etc. And it has been a useful way to deliver services during these challenging times. But who is being left out, and what other strategies have been tried to reach people without access to that technology? And specifically, for example, what about reaching adolescent girls and young women who may not have cell phones? So perhaps starting with you, Mata, and then others from the panel, could you speak to this issue around the access and how to enable more people to benefit from some of the innovations in terms of technology and outreach during these times?
Thank you for that question. So, like I mentioned earlier in my presentation, that yes, that's a real challenge in terms of reaching out to all telephonic interventions due to the issue of access to mobile phones. So, what we have been doing as an organization is profiling those who do not have a mobile phone or a phone in their household, so that these are the ones that we would then target with physical home visits, which are then, these physical home visits are conducted by the Zhandiri mentors who are working within those specific districts to ensure that all these beneficiaries are reached, because we know this is a challenge. So because we have got a database which we can extract all the individuals who have got phones and those who do not have a phone, as we register everyone that we support, it makes it easy for us to really then extract from the database who has a phone and who doesn't have a phone and who is using a borrowed phone. And this is an exercise which we actually did as a baseline at the onset of COVID-19 to assess this, so that those individuals, so that we don't leave them behind, or then reach them through isolated home visit, physical home visit support. And of course, the issue of phones is a barrier to services. So it's something that we really need to be thinking about. Thank you.
Terrific. Thank you very much. Would any other panelists like to respond to that? Perhaps, Anton, you mentioned the delivery of ARVs through the post. So that's a non-tech kind of approach. I wonder, could you speak a little bit more how other strategies within your work have been used, particularly to reach people without access to enough technology?
Could you please repeat the question? Or for people who don't have access to what? To
technology, like to a mobile phone.
Yeah. Because right now I'm scrolling this line of questions in the chat, and there are a lot of questions regarding the lack of access of key populations in particular countries or in general to the online approaches. Of course, talking about my community or actually other community, we are not counteracting one approach to another. So online things and sending by mail, it's not contraindicated, and it's not against the traditional outreach, face-to-face peer approaches. But talking about the COVID-19, of course, all the prevention measures should be there, like the social distance, masks, gloves, disinfectants, etc. So I mean, it's the same. If I understand the question right, because people are asking how to, if people don't have the access to mobile phones, etc. How do you provide these online consultations, or how do you provide this kind of the ARV sending registrations through some websites, etc. So of course, we restructured in Ukraine. The harm reduction programs were rebuilt, so they were not closed personally. So human resources are still there, people are still working, but outreach workers, they just consider every individual situation, and whether it's also individual personal consultation within which a person can have access to whatever she needs or she or he needs, like harm reduction supplies or ARV, because some NGOs have a community-based ARV distribution as well in Ukraine. Now it's available. Yeah, so that's maybe the answer.
Great, thanks very much, Anton. And just quickly on the same topic, a question's just come in terms of the mail out of ARVs. How are confidentiality factors taken into consideration there, particularly if someone lives in a joint household or something like that? Could you say a little bit more about protecting confidentiality through postal deliveries of treatment?
It's a question to myself, to Anton, right?
It is, yep.
Yeah. So it's a complicated question. Why? Because talking about the distribution through the, for example, mobile clinics, or when the NGOs bring in this ARV to you by car or by the social worker, of course, people are in our programs has just a unique code with non-personalized, so which not requires personal data. So you do not disclose, you're not disclosing your personal data to have this kind of plastic card of being the client and have access to these services. Talking about the mail, it's not obvious to mention the real name and surname of the person. The key thing is just the number of telephone, because we have mail services, not only the kind of the state mail service, but also other private mail courier companies, and it's not obligatory, it's not obvious to give the personal data of the person. So it could be absolutely another surname. There is just a control number of cell phone, for example, for kind of linking the person, but so it's not a problem in terms of disclosure of the personal data. But also talking about the relatives, for example, and family members, we are not providing, I mean, it's not obviously to send it to your home directly. You can just go to the closest post office or this courier service office and receive this ARV. It's not something which is unexpectedly coming to your door and your mother or father like unexpectedly realize that you are HIV positive.
Great, thanks very much, Anton. This question is for Surang and the experience of Swing in Thailand. Could you speak about how you've managed in terms of gender-based violence or intimate partner violence and providing those services for key populations, in particular sex workers, during lockdown?
Okay, thank you so much. That is what we do during for the gender-based violence. That is for what we do. That is okay. For our among staff, that is okay. We have every gender balance for the staff. That for make sure that if we are working with the female sex worker, that is the female staff. They have to take care of this group, but and also if we work with the transgender sex worker, that we have also the transgender staff also have to take responsibility for this group, and for make sure that we do not found the gender-based violence among the sex worker. That's okay. For the gender-based violence that we face, the sex worker they face from the police or from the authority, that we have the collaborate work with the police, try to reduce the problem. And also we start to have the one of the projects soon on the gender-based violence that is supported by the UNDP. That also we try to find the test kit and also the information that try to educate the sex worker themselves how to protect themselves from the gender-based violence. And also for us, okay, we have the hotline. That is if some of them they are face the violence, even the gender-based or another violence, they can contact us. Okay, our staff can ready to support them and helping them with all the time. This is what we are doing in our organization.
Thank you very much, Surang, for sharing further details on that. That's great. Perhaps one final question, and I'll direct that first to Mehdi from the ALCS experience, but then also to Chris and others in the panel. But a question that's come in a number of times is how do we monitor the effectiveness of online platforms and social media or other innovations during this period for actually delivering essential health services, and who that's reaching? Can we be sure that we're reaching the key populations and people living with HIV, for example, through the provision of those services?
So can I go?
Chris, first let's hear from the Moroccan experience. Sorry,
Okay.
yeah, as we haven't heard yet in the Q&A, but then over to you if that's okay. Thanks.
Okay, thank you. Can you hear me now? Yes.
Yes, thank you. Yeah.
Okay. So yes, of course, this is a challenge. Moving to online work or moving to the social media, we just didn't start from scratch. It is based on years of outreach work, of peer education. So the community agents, they know their community, and they have been in contact. So it just the mean of communication that has swifted from physical contact to digital contact. So, and also we had a survey that we conducted among people living with HIV to see if they know about this new service, if they know how to reach out, if they need to, if they had received their treatment, and we did that with the help of UNAIDS, and also in collaboration with the health authorities, and the results, I think 84% of the surveyed persons, which basically are people living with HIV, said that they knew about the service, and they knew to whom they can turn if they want this service.
Great, thank you very much. Sorry, Chris, now over to you.
Yeah, thank you very much. Just to highlight what you just talked about, in most of our countries, we already have existing online platforms that we're using to reach key populations, including linking them offline to services such as HIV testing. So what we have done is to leverage on this and to expand access to this. And I think for most key populations, for example, the MSM community that is closely knitted, like you mentioned, people already know themselves. We already have individuals who are in close groups who can invite others to join such groups. And through that, you're able to provide and link them to services. So in terms of being able to monitor how going online is helping us to sustain access to services, we're actually able to track individuals from the online platform through online outreach, track them to when they eventually go to test, because we have this online reservation hub that I mentioned during my presentation that clients can actually use to book appointments and make reservations at some clinics where they will go to uptake services. So right from that online platforms, you can track them to know when they go to the facility to test. You can also know, whatever the outcomes of the results of the test is, and whether they need support to eventually initiate treatment. So we have, and this is something we're trying to scale up now across multiple country programs. We are looking at online case management so that all individuals who eventually test positive can also be supported. So there's a lot that could be done by the clients themselves online without even requiring any physical support. And we should also keep in mind that even without COVID, a lot of our key population individuals prefer to remain anonymous for as long as possible. So this is something that was already existing before COVID. So we're now looking at just leveraging on this and expanding access. So we're able to track to know, how many people are due for their treatment, how many people did we reach, using telephone, how many people did we reach using online platforms, including social media platforms, and then be able to track, did they eventually get their medications? How did they get their medications? Did they prefer to get their medications at home? How many people are still going to the drop-in center or go to the farm? So there's a lot that that is happening within our space, and this presents an opportunity for us to actually expand on this. And we have also organized some internal webinar and external webinars looking at some of these issues. So we can discuss the details, but definitely this is what is happening. And as we continue to implement some of these, we're also tracking. And at the end of the day, we'll be able to tell clearly that, okay, this is what has happened. Maybe we're not going to reach where we ought to have reached without COVID, but we'll also be able to demonstrate that with the online platforms to a great extent, we're able to still maintain some services for our clients.
Fantastic. Thank you very much, Chris. Useful to hear more about the experiences from within linkages as well. I'd like to ask just one final question to all panelists as a kind of last word for today's webinar. And that would be, what would be one piece of advice that you would give to people listening that's been the most important learning, I guess, from how you have adapted during this period to still provide community-based HIV services? Just one thing, one sentence, your golden nuggets, if you like, of advice to share with the audience today. If I could start with you, Chris, and then we'll just go quickly through the order of speakers just to share that one sentence of advice as part of today's closing.
Yeah, thank you very much. I think the advice would be, for us to make sure that all our clients continue to access these services in a safe and friendly environment. Thank you very much.
Thank you, Chris. Surang?
Yes, can you please remind the question again, please?
Your one piece of advice for the listeners that you've learned from adapting during this period.
Okay, that's what we have learned. That is okay. We cannot separate. Okay, HIV and the COVID. That the COVID and HIV should be together. Yes, when we work with the target group, that's okay. We cannot leave the HIV behind, or we cannot leave the COVID behind. We do it together.
Thank you, Surang. Anton?
Yeah. So what I want to say is that many countries, and especially government authorities, they still live in the world of fears, and they are really scared, to change some approaches. But what we see from the COVID changes that many things were simplified and changed, like take-home dosages, and nobody kind of died. No, there was no kind of crash of the OST provision programs, etc. We didn't observe at the moment the increase of overdosage or something. So what I like to say, as simply as is better for people on the ground, and just respect the human rights and provide the real individual approach and based on the gender sensitive things, and that's it.
Great, thank you, Anton. Merdi.
Well, I'd say don't be psycho-rigid, and don't hesitate to go into innovation, and mainly don't let the officials get you cold feet if you think you have a great idea that may help your community.
Thank you. Mata?
Thank you. My key takeaway message will be, let's not leave anyone behind. I know we've been talking about the issue of access to mobile phones and all, but for us to ensure that we don't leave anyone behind, it calls then for the importance of planning when we are doing working with children, adolescents and young people, working and planning together with the nurses. As a community partner, you need to be working with the health facilities and also the nurses at the clinic to ensure that we do not leave anyone behind. Thank you.
Fantastic, thank you. And last but not least, Tanisha.
Yes, I would like to say that you may be isolated, but you are not alone. You need to access services, and there are people who can help you. You'll have to reach out. One thing you remember, you are not alone. We are there with you. That's it.
What a wonderful sentiment to end with. Thank you so much, Nisha, and to all the panelists for some fighting words there in conclusion. Thank you all for joining me and for staying on to the end. As you can see, there's a great interest and need to continue this discussion. And for more information on today's presentation, please do visit the IS website on COVID-19. The URL there is on your screen, and as soon as possible, within the next day or two, a recording from the webinar today and the slides will be posted at that website. And please do send any ongoing questions via email to coronaquestions@iasociety.org. I'd really like to thank the speakers again for such a fascinating and diverse set of presentations, and for staying on, because I think the Q&A session was equally rich in terms of the content and the advice and the pragmatism that's been shared today. I'd also like to thank the Swiss Agency for Development and Cooperation, SDC, and Merck Sharp and Dome MSD, our donors, without whom this webinar series would not have been possible. And I'd also just like to let all the participants know that as soon as this webinar concludes in less than 20 seconds, you'll be directed to an evaluation survey. Please do take a moment to fill that out because your feedback's really important to us and we'll consider that as we develop future opportunities going forward. So with that, I'd really like to thank everyone for joining in this rich discussion. Stay safe and enjoy the rest of your afternoon or evening or day. Thanks very much, everyone.